Hi, and welcome back to Perioperative Care. This is Tracy again. We're going to look now at the collaborative management and the assessment of our patients. This is going to be a wonderful time to gather data, really take a look at our patients, and try to gain a solid understanding of what is going on with them. So, first of all, let's consider their age. And as we look at age, again, we are going to be looking across the lifespan. So let's take a look at the child first. There's not a lot of research out there as to how surgery affects children. There is some basic stuff, but not a lot of information and research regarding child perception. So things that we do know, however, and refer back to your Perry Hockenberry book, when you're looking at children, it's really important to provide good education. So for education, we need to maybe provide films, books, brochures, and then possibly having them go to that unit and taking a tour, maybe playing with a few things, and just kind of familiarizing themselves with where they're going and where they're going to be. It's a very stressful time. We do know that. It's stressful for adults, so it will be stressful for our children. So stressful points during or before and after surgery, that admission process is going to be stressful. It takes a long time, lots of questions. It's a new environment. There's new people, new practitioners, multiple practitioners. So that's going to cause them to have some fear and uncertainty. Then you need to think about blood tests. And blood tests along with IV starts. A lot of times we won't see IVs being started until they go back into the surgical suite, but there are times that we do need to start kids as IVs. And so if at all possible, try to get those lab draws off of the IV to prevent an additional stick. NPO is another concern, especially for our infant population. So we want to schedule their surgeries early in the morning. Infants can't go extended periods of time without oral intake or IV fluids. But if we have them go extended period of times, what we're going to see happening is that these infants are going to get dehydrated. They're going to lack that glycogen store and suffer increased complications from the preoperative phase. If you take a look at table 45.1 in your Perry and Hockenberry book, you will see just an idea of recommendations to help reduce pulmonary aspiration in the infant and pediatric population. So you can take a look at that. So it's a good idea for our kids to have some type of preoperative sedation to help decrease stress, decrease anxiety, maybe reduce the possible long-term effects that this stressful time may have to them. So that'll be something that we do talk about when we talk about some preoperative medications. Now, if we're looking at the adult and across the lifespan, age is going to be important too. We know that as we age, unfortunately, the aging process decreases the immune system functioning. It's going to delay wound healing. Oftentimes, this population have chronic illnesses, which adds more risk for them in the surgical time. So we do need to consider that as far as our elderly population. Drug and substance abuse are going to affect how patients respond to surgery. If you think about tobacco use, and smoking does cause increase of secretions, as well as does some of the surgical procedures and the medications that the patient receives. So they kind of have a double whammy with increased secretions from smoking as well as from the surgical procedure. And we know that smoking does cause lung tissue damage, and so we need to pay special attention to our smokers and really key into them and educate them heavily on breathing exercises, especially to be done during that post-operative period. And even if they could stop smoking a day or two before surgery, that's often that can help, but they are going to be at risk for pulmonary complications. Excessive alcohol consumption and illicit substance abuse, possibly withdrawal symptoms or an adverse reaction to the anesthesia or a different type of reaction to anesthesia are going to be a couple of complications. And then you need to think about over-the-counter medications too. So is your patient taking aspirin? Well, what do you know about aspirin? We know that aspirin is an antiplatelet. It decreases platelet aggregation. With decreased platelet aggregation, we're going to have prolonged bleeding times. So we need to consider, is our patient taking over-the-counter stuff? How about herbal supplements? With all these diets that are out there, Advocare, Herbalife, I think there's one called The Works, even over-the-counter dietary medications. I can't really recall any off the top of my head. Dexatrim, some of those kinds of things, we need those patients to stop using herbal supplements and those types of things. Typically about a week before surgery. There is a list of herbs in your IGGI book, Table 16.4 on page 244, that just kind of talks about some of maybe the adverse outcomes from taking herbal supplementations and then going into surgery. Again, what's their medical history? Do they have cardiac problems? I kind of touched on pulmonary problems. Do they have cardiac problems? People that are seeing, people that have cardiac problems, we will typically see them being referred to a cardiologist, or at the very least having an EKG and maybe possibly an echocardiogram done prior to surgery, because we want to make sure that their heart is healthy enough to withstand the surgery. So cardiac and pulmonary are going to be very big. The complementary and alternative practices kind of refers back to that herbal medication, as well as what are some cultural beliefs, what are things that they might have, what special practices might they have. Previous surgery right here. We talked about previous surgery, previous procedures as far as their psychological health, but what about anesthesia? How have they acted or reacted to anesthesia in the past? Have they tolerated it? Did they just wake up throwing up, feeling just miserable? So those are going to be some things that we'd like to address prior to them going into surgery. Blood donation, if it's somebody that's having a total knee, total hip, did they make an autologous blood donation, and do we have that available? Are they willing to receive blood donations? Are they of a certain religious background that doesn't allow them to have blood transfusions, or those types of things are going to be important. And then we would like to look at discharge planning. Do they have everything that they need to be able to go home and take care of themselves once they are discharged from the hospital? Those are going to be things that are going to be of consideration to us as nurses. And we need to start discharge planning before they even go to surgery, because regardless of how minor the procedure or how often they have had surgery, they still need discharge planning. You can't just send them home and say, hey, good luck with that. I hope you do well. So those are going to be things that we need to continue to work on. As far as the physical assessment goes, obtaining baseline set of vitals. It's going to be very important to have that baseline set of vitals, because you need to look at how that patient reacts to surgery. And if they are asleep, or they've had a spinal or an epidural, what were their baseline vitals? Maybe you have a patient that has a perfect blood pressure, 120/80 going into surgery, and then all of a sudden we get into surgery and it's 200/110. We need to know that baseline set of vitals. We need to know where they start, because that's going to determine some plans of treatment for them while they are in surgery. And we want to make sure that we assess that pre-op, intra-op, and post-operatively. And part of that is that in the post-operative phase, those baseline vitals are going to help determine when they're ready to go back to the regular medical surgical nursing floor. Basically, with your physical assessment, you want to focus on the problem. What is the patient's problem? Why are they here? And what kind of effects is it going to have on their total body systems? Again, your chronically ill patient is going to be at increased risk. If they have serious problems, they're going to have increased morbidity and mortality. And then if you obtain any abnormal assessment findings, you need to let someone know. Say you get a high blood pressure your first reading. Okay, you know what? I'm nervous. I'm really anxious. I'm not sure I want to have this done. Blah, blah, blah. Okay, well, you know what? If you take that initial blood pressure and it's initially high, give them some time. Do some other things. You know, me, I'm scared to death of needles. So my biggest fear is getting that IV started. But you know what? Maybe once you get that IV started on me and you take my vitals, my blood pressure is probably going to be down some. So make sure you check it, recheck it, and then report that abnormal finding. If it's an abnormal, say they're going to have abdominal surgery and you notice a skin infection, those things, of course, you want to report right away. But abnormalities as far as vital signs, we want to take a peek at those and then make sure that we recheck those so that our patient, or so that when we report things to the physician, it's going to be rechecked. Neurologically, again, determine that baseline. Are they alert and oriented ×4? Are they alert but confused? Can they follow commands? Are they unable to follow commands? Is this your Alzheimer's patient? You need to have that baseline so that when this patient wakes up, we know where they need to be or where they were, because we don't, this is again to kind of help with that prevention of complications during surgery and then in that post-operative phase. If you think about the musculoskeletal, when you think of musculoskeletal, a lot of these problems may interfere with positioning during and after surgery. So we need to make sure that if they've had a history of a joint replacement, we want to make sure that we document these kinds of things. Because if they have a history of having a joint replaced and that prosthesis has metal in it, we don't want to put any of those electrocautery pads over, because that could cause electrical burns. So those things are going to be important. If your patient has contractures, it's going to take special positioning during surgery. We also want to think about their nutritional status, malnutrition, and obesity. There's going to be problems for both of these patients. Surgery increases our metabolic rate. It increases our metabolic demands. We need potassium, vitamin C, B vitamins, all for wound healing. We also need vitamin K for blood clotting. So our malnourished patient may have decreased protein levels and not be able to heal appropriately. The obese person, they oftentimes have many comorbidities, and so we want to, that's going to be important to be addressed. Indications of poor fluid or nutritional status include brittle nails, muscle wasting, dry flaky skin, poor skin turgor, orthostatic hypotension. So if you think your patient might be dehydrated, check those orthostatic blood pressures. The obese patient, they are oftentimes malnourished because of all the excess fatty tissues. We know that increased weight will have effects on our heart. It makes our heart work harder, and oftentimes they do have poor wound healing, especially if that wound is in a place that is covered by a panicula fold, so maybe they have an extra skin fold. That's going to be important to be looking at those. Look at their skin, make sure you document any open sores that they may have, and continue to look at those pre and post-operatively. And then that psychosocial assessment. What is their anxiety? What's their coping ability? And then do they have support? Those things are going to need to be considered during this time frame so that we have better outcomes for our patients. This is where I'll wrap up this voiceover, so please continue on to the next.